All right. Okay. Um, so I'm Jin-Xiong, and I most people call me Jin now, and it's much easier. I have been an academic scientist for a little over 40 years, and in the past 40 years, I have done extensive research, primarily focusing on biomarker discovery and implementation in clinical settings, and also a little bit on drug development. My career has always been about disease prevention and how we can identify high-risk individuals and then come up with primary and secondary prevention strategies. My earlier career was focused on childhood disease, especially type 1 diabetes. I have one of the largest research programs that have ever been attempted, and we screened over 500,000 newborn babies and identified over 10,000 high risk babies that we monitored for over 20 years. And we studied, everything about these children for a very long period of time. And we were able to identify, uh, develop new screening strategies and also uh, potentially prevention strategies. So from the childhood disease and especially type 1 diabetes, obviously we are very interested in the whole body because diabetes, as you know, is a disease that impacts almost every single organ in our body. Because I became not so young, I obviously and selfishly became very interested in longevity. So that's what I have been doing in the last 5 years, and for the past 3 years, I was on my own and I started my own program that are using the academic experience and technologies that we developed in the past decades. So my personal goal is to be the next one, Henry Young, and that's who is on this slide, 102 years young gentleman, and I think he's the first person who participated in a tennis competition when he is over 100 years old. So I I'm tr what I want my passion now is to be able to help myself and others to uh, beat what Henry Young can do. I mean, he has a great last name, Young. Being young is great. So, so how we can, what I'm trying to tell people is how can we play tennis at 100 years and beyond? So what are the things that we can do now and potentially what we can do in the future? And obviously there are many, many things that one can do to extend the health span and lifespan. Because of my own expertise, obviously I focus on biomarkers and how we can use biomarkers to develop a personalized and precision longevity plan for each person. So I want to start by defining biomarkers. Everyone's talking about the biomarkers, but I think we need to define a little bit. And obviously, a biomarker can be very broadly defined. Is anything that we can measure inside our body or outside of our body that's secreted by our body. But also a biomarker should have some biomedical utility. And you can measure many, many things if they are not useful for health or for medical purposes, they are not really great biomarkers. So, and if you look at the what can serve as a biomarker, and there are many different types of molecules. And if you go through the biological information flow, it starts from DNA, and then it goes to methylation or epigenetics, and then it goes to the transcriptome or messenger RNA, and that are transcribed or translated into proteins. And proteins can be modified by many different processes, glycosylation, phosphorylation, acetylation, and so on and so on. So modifications of proteins are very important for molecular functions and cellular functions. A very good source of biomarkers as well. And then you can look at the metabolome, the metabolites from cellular processes, and all the way to cellular functions and tissue functions, and even the whole body physiological functions. So all these different molecules and functions can potentially serve as good biomarkers that we can use for patient care, or in my case, for longevity purposes. So now, what biomarkers are important for longevity? And this is the area of rapid progress. And initially, now almost 2 decades ago, and 9 hallmarks of aging were initially suggested. And these 9 hallmarks are listed here. They are genomic instability, telomere attrition, epigenetic alteration, loss of proteostasis, and deregulating nutrient sensing, mitochondrial dysfunction, cellular senescence, stem cell exhaustion, and altered intercellular communication. So these are the initial 9 hallmarks of aging that many people are looking for aging biomarkers. It's a good starting point, and the hallmarks of aging were extended to 12 and about 2-3 years ago. And obviously, these are very good starting points, but I have been looking at this question in the last few years. I can actually come up with 30 different hallmarks of aging that I put into 6 categories. And I don't want to spend a lot of time to go into these 30 different hallmarks, but you can see they range from the molecular level, molecular alterations, to cellular level. And then the next level is how cells talk to cells, or intercellular communication. And then you can look at the tissue level, or the organ levels. And then finally, in the last 2 categories, these are 2 categories that people don't pay enough attention, in my opinion. And that's how our body interact with the microbiome, and microbiome is actually becoming very important, and it's a very important area of research and application. And finally, how we as a living being interact with our internal environment. And we are majorly impacted by the environment at large, whether it's air pollution and how we respond to pathogens and to allergens, and also our ability to adapt to the changing external environment. All these different parameters can have a major impact on the aging process, and on how long we can live and how well we can live, and certainly on what diseases we may develop at some time point of our life. So there are many, many things we can measure, and there are many, many things, biomarkers that can be used. But in you know, in real life, it's very hard to measure potentially meanings of different biomarkers. I mean, we now have the technology to measure many of them, but we don't have the knowledge on how these potential biomarkers can be used. So how do we choose what to test in a clinical program or in a wellness program? So these are three important criteria that one must think about when we decide what biomarkers to test and how we can use them. The first one is there enough scientific evidence? Are the biomarkers clinically relevant? Is there a good utility for what you can measure? And this is a very important question that I think we should keep in mind. The second criteria is more technical. So for any good biomarker, you have to be able to measure them reliably and reproducibly, and also over time. You do not want to have drift of the assay. Otherwise, it cannot be implemented in a clinical setting. And finally, I think that's very important is can the information, can you act upon the data from the testing? Is the actionability of a biomarker is obviously very important. Now, there are many biomarkers that we can measure and that can provide important information. But if we don't have an intervention, if we don't have a way to marginate the findings, then I don't think they should be the first line of biomarkers that we should be testing, because they are, frankly, a large number of biomarkers that can potentially be tested and used. So what are the potential utilities of biomarkers? Why do we want to have biomarkers? Why we want to test them? So the first purpose is to identify abnormalities or deficiencies. And then we also want to define the optimum range, which is different from a normal range. In a conventional medical setting, and most doctors talk about normal range. A normal range is not necessarily optimal. I think being functional medicine or integrative medicine doctors, you would appreciate that. And we're in the business of optimize human physiology, and we want to bring all the parameters to the optimum range instead of what's called a normal range. And biomarkers can also be used to evaluate efficacy of interventions. That's a very important application. And very often, even nowadays, it's very hard to know whether a treatment or intervention is actually doing any good, especially when you are talking about longevity or wellness programs. So biomarkers can be used to help us to evaluate how good the program is working. And also biomarker testing can provide information that can be used to adjust the actions and adjust the dosage of treatments, whether it's drugs or supplements. And finally, we want to keep in mind that safety is should be the number one priority of any programs. And I work with many biohackers. Unfortunately, many of them are not really doing are helping themselves, and they are potentially really harming themselves because they just randomly take stuff and they don't know the dosage and they don't know what's doing to their body. So safety concerns are extremely important to me. So now, I told you that my goal is to be able to play tennis at 100 and beyond. So what's my recipe? And the recipe that I preach about is called Tao. And Tao derives from the Chinese ancient Chinese philosophy, Taoism. That's on the right. And by in longevity, what I'm preaching is a program that's based on test, act, and optimization. And the Tao program is actually a iterative loop and of testing and action and retesting. So you just continue this loop on and until one day we have to go. And my goal is to live as long as possible. And then when my time comes to leave this world, and I want to go fast, and I don't want to suffer for too long. So now, so I looked at a large number of biomarkers that are potentially useful for anti-aging programs, and these are the 8 categories of biomarkers that I consider very important. The first one, you are very familiar with many of these, if not all. The first one is mitochondrial dysfunction. And many people believe that mitochondria is the basis of many diseases. I agree. And in relation to mitochondrial dysfunction, is oxidative stress, which is a byproduct of the mitochondrial function. I'll come back to this point in a little bit. Inflammation, everyone talks about it, and cellular senescence, and a lot of uh, anti-aging and doctors are paying attention to this, but the conventional doctors really don't know much about it. Uh, we were talking about the cursor, and before we started this presentation, that obviously is very important. And the next category is micronutrients. There are many of them, a lot of the vitamins, minerals, and they are essential to our health. And the last two are pretty conventional metabolic functions and tissue damages and so on. So these are the 8 categories that I focus on. Obviously, there are others that can be very important. Another one that I think is very important, but no one can really test is autophagy. And I would love to get a autophagy assay in place, but I have been trying. I will continue to try, and uh, and there are other biomarkers that can be very important as well. But this is enough to get started. So I'll go through some of these biomarkers and tell you what we are trying to do. So the first one is chronic inflammation. I don't need to tell you too much about it. You, you know how important it is. And the only couple points I want to mention here is, yeah, you have a question? Someone has a question? Well, so inflammation is to a large degree related to cellular senescence. And senescent cells actually secrete a lot of the pro-inflammatory cytokines. and they actually secrete over 4,000 different proteins, and many of them are pro-inflammatory cytokines and chemokines. And there's many different types of inflammation. So being able to identify the types of information and the sources of information can really help us to identify the issues with the patients. So, being able to test a large number of inflammatory biomarkers will become more and more important in clinical medicine. And I to illustrate the importance of inflammation in aging, and we can look at this chart on the left. As you can see, individuals who have higher high sensitivity CRP, and the survival probability is increased by over 10% just by having a slightly elevated CRP. 3 milligram per liter is actually not very high. We see about 20 to 30% of individuals having CRP levels greater than 3 milligrams per liter, and this are in the so-called healthy population. So inflammation is quite widespread in even so-called healthy individuals, and obviously in patients, many of them, a very high percentage of them have moderately to highly elevated CRP levels. So getting inflammation under control is a very important tool for anti-aging clinics. Now, with CRP, you really want to lower the levels as much as possible. And conventionally, CRP greater than 1 milligram per liter is considered at higher risk for cardiovascular disease. But what we do know now is those individuals who have less than 0.5 milligram per liter of CRP have a much lower all-cause mortality than individuals who have around 1 milligram per liter of CRP. So the lower CRP you have, the better survival you have. So you really want to bring down the CRP levels, as close to zero as possible. And that's an important point for me to say. Now, then I want to quickly run through some other biomarkers to highlight how the conventional tests you can do, how they can be used for longevity medicine. And glycation obviously is a diabetes biomarker. Glycation can be measured by a few biomarkers, and the most popular one is hemoglobin A1C. Another one that's less known is called the GSP, or glycated serum protein. And here you are looking at the hazard ratio of HbA1c in a diabetic population on the top graph. And obviously, HbA1c is associated with all-cause mortality, but even in healthy individuals who don't have diabetes, and A1c levels is also associated with all-cause mortality. So you really want to get A1c levels into the optimum range, which is in the middle. If it's too low, it's not good. Obviously, too high is not good. And here is another very routine biomarker that people may or may not pay much attention, uric acid. Now, uric acid actually has a very major impact on all-cause mortality. If uric acid level is greater than 9, and the life expectancy is decreased by 10 years. And so, all these conventional biomarkers can be very important longevity biomarkers to consider, and we need to monitor them routinely. And so here is a survival curve for uric acid, and you can also look at the ratio of uric acid over HbA1c, and the ratio improves the death prediction a little better than uric acid. But just by measuring uric acid and HbA1c, you can see the all-cause mortality difference, how big the difference is between individuals who are in the optimal level versus the ones that have high elevated uric acid. And ALP is another one, and a conventional biomarker, and it has a major impact on all-cause mortality and as well. Vitamin D, and again, it's very important, and all doctors, at least the functional medicine doctors and integrative medicine doctors, know the importance of vitamin D, but perhaps fewer know how important the vitamin D level is. And on this graph, as you can see, how big a difference on the survivability of individuals with different levels of vitamin D. And the difference is astonishing. There's almost a 50% difference between individuals with optimum vitamin D levels, and actually I don't consider 30 nanogram per ml optimum. You really have to get your vitamin D levels to above 50 nanogram per 50 international units. And so unfortunately, 70-80% of Americans are still deficient in vitamin D. I mean, this is a very simple, very cheap intervention that everyone should be able to get on and increase their longevity by years. There are a lot of simple actions one can take to increase life expectancy and health span. Now, so those are the conventional biomarkers that are important for longevity. Now let's talk a little more about the newer biomarkers, and that have really will become even more important as we get more scientific evidence. Now, cellular senescence, I talk a little bit about it, and this is becoming extremely important in anti-aging medicine. Now, what are senescent cells? Senescent cells, well, cells are programmed to die, but some of these cells that are programmed to die refuse to die, and they don't function normally anymore, but they refuse to die. They sit there and don't carry out normal function, but they secrete large numbers of what's called SASP, or senescence associated protein. And these SASP proteins and other molecules uh, can have a major negative impact on normal cells around them, but they can also be secreted into the bloodstream and travel to other sites of the body and cause harm. And so senescence is one of the uh, most important characteristics of aging. And so senescence is increased with age, and aging also promote senescence. So this is a two-way street. And senescence can have a major impact on mitochondrial function, and it can also have impact on uh, DNA function, can have an impact on another very important molecule called NAD. I'll spend a little more time on that later on. So senescence is something that we need to pay much more attention. So there are unfortunately no great ways to measure senescence yet. Currently, there are two different assays available. The first one is analysis of uh, T cell populations in the blood. You basically measure uh, the proportion of naive T cells in the circulation. As you can see on this slide, the naive T cell proportion actually goes down with age. And this is considered as an indication of immune senescence. Now, immune senescence obviously is important, but it only measures senescence in the immune compartment. The second biomarker for senescence is a lysosome enzyme called beta galactosidase. Sometimes I call it beta gal for short. Now, beta gal is a lysosome enzyme that's relatively specific to senescence. And so beta gal levels are increased in a number of disease conditions, and you can see the data in a large cervical cancer population that we studied 4 or 5 years ago. And on the right side, you can see high levels of senescence actually have a major impact on how cervical cancer patients respond to chemotherapy and their overall survival. The bottom line is the higher senescence the patient has, and the less response the patient has to chemotherapy, and the patient's and the shorter the survival of the patient. So you really, I believe that this data indicate that you can reduce the senescence in cancer patients to improve cancer treatment. And this is something that I actually was going to conduct some clinical trials before I left my academic position. If I can, get some resources, I'm going to study this question a little more. I think that really has a great potential in cancer treatment and also in some other disease settings. Now, so I'll talk a little bit about the closer, because it's becoming very hot, and almost every meeting I go, and someone is talking about the closer. Now, What's cortisol? Cortisol is a protein that's primarily secreted by the kidney. It's also secreted by brain cells a little bit, but most of cortisol is secreted in the kidney. And cortisol has uh, a, a number of functions, and it has a major impact on the function of many different organs, obviously kidney, heart, and it can have an impact on diabetes, cancer, and COVID. But um, I think closer becomes very hot now, because it's related to longevity, and the protein is actually named after the Greek goddess, and who determines how many years that we have. So that's how important it is. Now, so there are a number of factors that can decrease cortisol levels. And I listed three here on the right. The first one is oxidative stress and inflammation. And the third one is psychological stress and depression. These are only three. What we have found recently is cortisol levels are highly responsive to disease and the physiological conditions of the person. I can give you my own personal experience. So about my cortisol level was usually in the middle of the optimum range that we define. And about 3 months ago, I got COVID, and I measure all my biomarkers all the time, especially when I become sick. What I found is my cortisol level dropped from 6 to 0.8. You know, 0.8 is really bad. And we don't want the levels to go much below 5, let alone, 1. So what we have found is extremely low levels of cortisol are associated with cancer and post-COVID syndromes, obviously kidney diseases, and also Alzheimer's disease, and and they are also a number of other diseases that we find cortisol deficiencies. And what's really interesting is that how fast the cortisol level can change. That was not expected. And it's almost a protein that behaves like a CRP. And as you know, CRP changes very fast to infections, surgeries, and other physiological or pathological conditions. And I believe cortisol will be a great tool that we can measure uh, and identify pathological and physiological abnormalities that's happening in an individual. So that was really a surprising finding. I think that will make cortisol highly useful for clinical medicine. Unfortunately, I didn't know that this group is so interested in cortisol. Otherwise, I would have included some data slides. All right. Obviously, the next question is how you can increase the cortisol level, and there are a number of suggested solutions, and there are some supplements that are suggested as well. There are gene therapy programs in place. and there are companies that are producing the closure protein and for injections. And what I have found is, the gene therapy program may work pretty well, but it's going to be hard for it to become a mainstream treatment modality because of the cost and other issues. So we really have to find other um, pharmacological solutions. And many some clinics and companies are working on that, and I have been working on that as well. We have something, but we don't have a great solution yet. For the time being, what we have found is if you can improve the health condition of the patient, you can actually improve cholesterol level. And so if you identify health issues and low cholesterol levels, and if you improve their conditions, and their cholesterol levels are likely going to go up. And obviously, if you can increase cholesterol, you will probably speed up the recovery. And especially if you increase cholesterol level, you can reduce inflammation, because many of the cytokines are controlled by the cholesterol protein. So while at the very beginning of exploring the application of cholesterol, and this is an area that I believe we'll see a lot of progress in the coming years. All right. Uh, so for the remaining of the talk, I want to focus on mitochondrial dysfunction, and and I want to start by talking about a byproduct of the mitochondria. As you know, uh, free radicals and reactive oxygen species are produced in the mitochondria as a byproduct. And these free radicals can damage various molecules, DNA, RNA, lipids, membranes. And what I want to tell you is oxidative stress is very common in America, and much, much more common than in Europeans. Over 70% of Americans have high oxidative stress that we can measure very reliably, very accurately. If you look at the Europeans, and it's only about 10%. So there's something that we do in America that's causing high oxidative stress. And the likely risk factors are lifestyle, especially food source. And so again, oxidative stress is a major contributor to various diseases, including cancer. As you can see on this graph, and oxidative stress is increased in cervical cancer patients, and high oxidative stress is associated with poor survival in cervical cancer patients. And we have similar data on many other different diseases. So we need to pay much more attention to oxidative stress, even more than inflammation. Although everyone talks about inflammation, very few people talks about oxidative stress. Every time when I have a chance, I want to bring your attention to oxidative stress, which is so common in this country. And if we can get it under control, we are going to improve people's health dramatically. Oxidative stress is associated with all-cause mortality. I'm not going to bother you with the details, because I really want to leave some time to talk about the NAD molecule. And you all know NAD, and I call it the supernode of life. And that's because NAD as a coenzyme is essential to the function of over 500 enzymes in our cells. The most important function of NAD, as you know, is the production of ATP in the mitochondria. Now, with each glucose molecule, we produce about 36, 38 ATP. Only two ATPs are produced outside of the mitochondria that don't really require the help of NAD. The vast majority, 95% of ATP, is produced in the mitochondria and then requires the involvement of NAD. Obviously, if you don't have enough NAD, your mitochondria is not going to function in an optimal way. So that's why NAD, that's the number one reason why NAD is so important. But there are 500 other reasons why NAD is important. So unfortunately, NAD levels decline with age, and that's commonly known. What was really surprising to me to find out in the last few years is that how fast NAD levels decline, how early the levels decline. It really, if you look at the very young individuals, teenagers, on the first bar, about 25% of teenagers are already suboptimal or deficient in NAD levels. And then if you look at the individual in their prime time, 20 to 30 years old, and 25, 20, only about 25% of them have optimum NAD levels. Then when you go to the group in their 50s, 60s, and their NAD levels is less than half of what you see in the teenage years. So this sharp decline in the late 20s, early 30s is actually associated with the decline of our physiology and our physical abilities, which peak around 30 years of age. So the NAD decline is probably responsible for a lot of the decline that we see as we age. The good news is that there are many potential ways that we can get the NAD levels increase. I rather prefer to use the word optimize. And so without getting into too much of the details, and you can give people the NAD molecules, their pros and cons. You can give people the building blocks or the precursors that the cells can use to make NAD, or you can try to inhibit the consumption or decrease the consumption of the NAD molecule. And finally, you can increase the enzymes that make NAD. So these are the four major approaches that one might consider to increase or optimize NAD levels. And that people are arguing about what works the best. There are debates, and that will continue. But I can tell you that we have looked at all these different approaches. I'll show you some data very quickly. The first data point I want to show you is a clinical trial that was done with NMN formulation with 4 different ingredients. It's a CME. I'm not going to tell you, whose product this is. And now, if you look at this clinical trial, on the left, we have 2 baseline measurements, and the average is about 28 micromolar, and that's actually on the higher side than other groups that have been studied. After 2 weeks of NMN supplementation, on average, the NAD levels increase by a little over 100%. In the next 2 weeks, it continues to go up a little bit, but not much. You really only need about 2 weeks. Actually, in many individuals, less than 2 weeks to get an NAD level peak at net concentration. All right, so they are very efficient ways of getting NAD increase. Now let's look at some other. Oh, I don't have the other data here, but what it looks like. But we can discuss it after the presentation. There are other ways, and they don't work as well as the NAD precursors, whether it's NMN or NR. Now, the one point that I really want to make here is NAD is so important that if you get NAD optimized, your other treatment may work much better than otherwise they can. I want to explain this slide to you. On the left is a study on what's on the impact of NAD on anti-inflammation treatment. If you look at the group that have a higher NAD level, about 80% of these participants responded to anti-inflammation treatment, and 20% of them did not respond. Then on the right side, if you look at NAD low group, only about 30% of the participants responded to anti-inflammation treatment, and 70% did not. Okay, so what the data argue to me is, if you have a good NAD level and you treat them for inflammation, your protocol would work better. The same is true to reduce oxidative stress. The data are shown on the right panel, where almost the mirror image of the inflammation treatment. So we have similar data on multiple other treatment protocols, and the bottom line is, if the NAD levels are optimized and your other treatment protocols can potentially work more effectively. So that, to me, you really want to consider getting the NAD optimized for all your patients. So, all right, so now here is a heat map, a color code map of individuals by biomarkers. Now, if you see red and orange and yellow, these colors mean that the biomarkers are abnormal or deficient. And red is the most deficient. It follows the emergency color code. Okay, red, orange, yellow, and white. White is optimal. So what I'm trying to tell you here, what I'm trying to tell you is, everyone is different. Everyone has a different set of issues. And in order to treat a patient more effectively, you want to know what are the top issues that are going to I don't want to use the word kill, but actually it is, because if I'm talking about longevity, I want to identify the factors that are going to kill me first. If I can take the top 3 issues away from that patient, I can likely give them 15, 20, or even 20, 30 years of extra life. So you really want to prioritize what actions that each patient should take. And with a comprehensive biomarker testing, you are able to identify the main issues. And I think a holistic approach is really how we can get the best outcome. And I know that every doctor is specialized in their own specialty. They have their own expertise. I think that's perfectly fine. And but if our program is to increase lifespan and health span, which is what I'm interested in, a holistic approach, a comprehensive approach, is really necessary. And the only way that we can have a highly effective program is through personalization, precision, and prioritization, and so on. So I'll give you a couple of three, I think three examples, and that we have seen. And the first one, now this is a gentleman in his middle 70s. The guy is super rich. Okay, he sold his company for $500 million, and has plenty of money, and he was even involved in the health business. And when we tested him, what we found the number one issue was his GSP, the glycated serum protein, was going through the roof, higher than anyone that I have ever seen. So he has been having diabetes, I'm sure, for a long time, and he was not paying attention. And his doctor didn't pay attention. So, and after our test, and we send him to his doctor, and we are getting his diabetes treated, and how many years we can potentially give this guy. I think it's not difficult to ask that. Well, if he does what he should do now, and we potentially give him another 15-20 years of healthy life than otherwise. So that was a very simple situation. Now on this patient is much more complicated. So after the test, we identified a number of issues. Here I'm listing the top 5 issues here. The first one is extremely high oxidative stress, as indicated by ROM, the first one. You can see how high it is, red. The second one is severely deficiency in NAD. And the third one is inflammation, as indicated by CRP. And he also has high triglyceride, increased LDL, and some metabolic issues, and also extremely deficient in vitamin D. All right, all these are simple issues that can be fixed. And how much the impact of these deficiencies have on this person is huge. We have solutions to fix all these what I call sub-health issues, and if we can fix them, which we can, and we should be able to prevent major diseases years down the road. All right, so this is another individual, a retired health executive, and we test the number of biomarkers in our panel. And so the 2 major deficiencies we identify, problems we identify, is number one, NAD deficiency that we were able to correct very quickly after a few weeks. And then another major one is his cholesterol was extremely deficient, less than 1. And he is actually a cancer survivor. And some cancer patients and also cancer survivors have extremely deficient cholesterol levels. And it's something that we were able to improve over time. So as we improve this sub-health issues, and we were able to improve his liver function. And another major improvement that we got was his muscle mass was increased significantly, as indicated by the creatine kinase and also by creatine levels and also by muscle scan. So, and with these few simple fix, what he got was increased the energy, reduce the fatigue, and increase the muscle mass, and his aches and pains were gone, and he's starting competitive recycling at age of 78. So, they are very simple fixes that we can have if we can identify the issues. That's what I'm trying to emphasize. Okay, so we can help individuals in their later stages of life, and we can also help very young individuals to increase their performance, like this young lady who ranked number 16 in 2023 in 100-meter sprint. And we worked with her in 2024, and she moved up from number 16 to the top 3 in 100-meter competition in the US. And we can also help individuals engaged in endurance. And Ted is a very interesting guy, and he was the first one to row his boat from California to Hawaii about 5-6 years ago. Then he had a heart attack, unfortunately, when he was planning to go from Hawaii to Australia. And he had to delay that trip. And with, partly with our help, and he was able to accomplish the mission as the first person to row a boat from Hawaii to Australia about 3 months ago. And now, how about a super athlete like a boxing champion? So Cena, you think he would be perfect, right? But not necessarily, and they may be performing at their peak, but they are potentially underlying issues that can cause problems years in the future. What we found with him is a severe deficiency in NAD, and less than 20 micromole in red color, you can see here. So after only 15 days, we were able to bring his level from 18.1 to 64.9, and that's really going to give him a lot of help, not only now, but for his health years or even decades down the road. So a physical appearance of health may not necessarily mean that you don't have underlying sub-health issues that if you can pay attention to get them corrected, that will give you much better health years, decades down the road. That's the point I want to make. Every time I want to talk about myself a little bit, obviously, because I don't preach anything that I don't do myself, and I have benefited tremendously from the program that I have developed, and the program is actually developed with me as the first guinea pig, and I got so many benefits, including my asthma is gone, my sciatica is gone, but what I like the most is my tennis game improved by at least 25 years. So I'm about 25 years closer to being able to play tennis at 100. That's what I like the most. My final, I think it's my final slide. I want to emphasize that how you can use biomarker testing to optimize. And this is an example on NAD optimization. And this young lady, she was 68 years old when we started working with her. and she was extremely deficient in NAD. And then we did not have a good product at that time. And so we were experimenting with various products on the market, and nothing really worked very well until we find another one that got her way over the optimal range. And we had to titrate her dosage down to bring her level to the optimum. So testing is really important. Not only many products may not work, but some products may work too well and bring levels to a harmful range that needed to be brought back. So the only way that you can do it in a very precise way is through testing before and after intervention. This is a key point to keep in mind. So, and this is my final slide, and I want to leave with you with 9 words. The first one is Tao, T-A-O, and that's the iterative process. And also, I want to leave with you with 8 words. Let's start with P. Proactive, predictive, preventive, precision, personalization, parallel, which holistic, prioritization, and persistence. And as doctors, you understand what this means. And I want to emphasize, especially with layperson, how important it is to be proactive, preemptive, and it's never too early and too late to start a longevity program. My 7-year-old daughter already started her program. And also it has to be really persistent to get the best outcome. And with these 9 words, I want to thank you for listening to me, and I'll be happy to answer any questions. Thank you.
Thank you, Dr. Shi. I got about a million questions, but can we start with the ones that are in the chat first?
All right.
How difficult is it to get clotho levels? Where do you
get it?
Where do you
get it measured or get it increase?
Either. I mean, I wouldn't even know. Where do you order it? I mean, who's doing clotho?
Okay, so so there are two laboratories in the US that can measure clotho level. And I'm not since we're still in the CME portion, I guess. Well, I'm not going to say. I
think we're okay to mention them. We're not endorsing anybody. We're just for information.
Okay, so the first lab is based in San Diego, and they offer a clotho test. It's a relatively expensive test, and the second one is from Gfinity, and closure level is tested as a part of a panel. So these are the only 2 laboratories that I know that can offer a clinical test for closure levels.
Okay.
Now,
when you get a chance, can you just type that in the chat so that we can see it?
Yeah.
We say the names.
Yeah, I'm not sure of the name of the San Diego lab, but I can find out for you later on. And the other lab,
clotho years.
Clotho years. Okay.
Okay, it's for $600.
Gfinity. That's the other lab that can test for clotho level.
Mm-hmm.
Now, in terms of how to get a clotho increase, and there is a company that does gene therapy. It's called Bioviva. Bioviva is a California-based company, and they offer a gene therapy protocol to for cold sore. And I can put it in the chat, Biomarkers. And I don't know how much they charge, and I know the CEO. I mean, if you are interested, I mean, I can find out later on. And they are also uh potentially some supplements that can may help, but how there isn't a single supplement that can really increase cortisol level for sure.
Mhm.
And my overall suggestion is you want to you want to improve the overall health of the patient. And there are also some cortisol protein product on the market. I frankly I doubt they work because the closer proteins that people are trying are produced in bacteria. Now, bacteria cannot glycosylate the proteins, and I think glycosylation of chlorine is important for its function. So I'm not sure any chlorine protein on the market actually works. So at least I don't have any data to indicate that it may work.
Okay.
And then I think the only widespread solution is to treat the symptoms and reduce inflammation, reduce oxidative stress, and and get them to a healthier state. I mean, I tell you, my cholesterol went down from 5 point something to 0.8, and I was able to get it back up to a little over 6 now. And I didn't take anything that's specifically designed to increase cholesterol because I don't know how. But I was just taking care of the issues associated with COVID. I was able to bring it back up. So this is a area that we're still experimenting. I'll be happy to work with everyone who's interested in this. Let's work together to come up with better protocols. And
Okay.
unfortunately, I don't have a great solution for you. Unlike NAD, NAD, I know how to do it. With Closer, I don't know yet.
Okay.
Dr. Shi, I was doing a podcast about it, and I actually was surprised about prescription medicines raising clotho levels, such as ARBs for hypertension and also statins.
Yeah, I know that's talking about in the literature. I don't uh, I don't have any evidence to indicate one way or another, and it will be. I think we should do a study. Let's try. And if it works, great. If it doesn't, I don't know. I have suspicions if you want, but
Well, another one that I saw was high phosphate diets are actually detrimental for your clotho levels, meaning it was pertaining to specific processed food. So, as we all know, we're exposed to processed food every day with the American diet. And that's why it has a big correlation when you mentioned about the kidney producing clotho.
yeah.
And as you would know, with chronic kidney disease, patients low phosphate diets are being promoted. And that's pretty interesting for me because as you can see, you could do any anti-aging modality exercise diet, but this was pretty specific about clotho levels. A low phosphate diet will increase your clotho levels.
Well, again, there are many suggestions. I have multiple clinics that are trying to come up with a causal protocol. No one has succeeded. At least the ones who have been working with me have not succeeded yet. if you were someone who want to try any protocol, let's work together. I'm open-minded. I want to find a solution. And what I'm telling you is I do not have any validated solution, even though, I got my close level, it went down. I was able to get it up, but we work with quite a number of individuals. The most efficient way to get a closer up is to improve the person's health. That's something I know. I'm pretty confident, but I cannot pinpoint to anything specific that I can tell you. You take this, or you do this, your closer will likely go up. I don't have that evidence.
I think we could deal with this. You know what I mean, Dr. Nario? Straight up.
We're gonna get on. We gotta beat
Dr.
you gotta beat Dr. Joseph and Dr. Halassa to the punch on this one.
Oh, geez. There we go.
There's a question about G6PD deficiency and being able to process NAD.
Right. With vitamin C. Correct.
Yeah, that has been talked about, and I do not have any data on that. And I think it's a question that we probably discuss on the Dr. Hana's group as well. And I don't have data. Again, if you have the patient, let's get some data.
Okay. Is there any other amino acids to support the pyruvate pathway, like D-ribose?
D-ribose, and we actually have D-ribose in the formulation that I talk about that we have the best outcome. And so D-ribose is certainly I think it's important for increasing NAD levels and many other functions as well.
Okay. What test are you using to measure NAD?
It's an enzymatic chemical reaction, and it can be done with a dried blood spot and a finger prick.
What about those little saliva strips that usually it comes with? Is that
we are not measuring
nitric oxide? I think I'm getting them confused.
That's nitric. That's nitric. You can measure nitric oxide with saliva, and you measure DNA. DNA test can be done with saliva, with actually cheek swab, not saliva, and we measure DNA with blood, and there is DNA in the saliva, but saliva, we don't know how to interpret the data from saliva. It's not necessarily correlated with cellular NAD.
Okay. That's all I have. Dr. Nario, you have some email questions?
Yeah, so as I told you, Dr. Shi would bring in all the NAD questions here. So, well, I think this is a big debate already out there. Maybe we can take your thoughts on this. Which is the better precursor to increase NAD? Nicotinamide riboside, nicotinamide mononucleotide, niacin? What is your take on that?
All right. So now the best precursors are NMN and NR. They are comparable in elevating NAD levels. I know there's a debate between NMN and NR, and but I think those debates are really not based on actual data. We have a lot of data, so both NMN and NR can increase NAD levels. If you give a comparable dosage and in molarity, and they can increase NAD levels in a very similar way. Now, personally, I prefer NMN over NR a little bit for two reasons. The first one is NMN is a one-step precursor to NAD, and NR is a two-step precursor. Now imagine that someone is deficient in the enzyme that converts NR to NMN, which is NR kinase or NRK. If you are NRK deficient, and you wouldn't be able to use NR. What I don't know is what proportion of the population is deficient in NRK. And I don't know, but there is a possibility. The second reason that I personally prefer NMN is that both NR and NMN have their own biological functions, and the biological function for NMN seem to be a little more important. And we seem to get a little better functional benefits from NMN than NR. But in terms of elevating NAD, both NMN and NR should be fine. Now, niacin, I think we had a discussion on niacin. Niacin is very effective in elevating NAD levels in some individuals, but if you take high levels of niacin, you can get an NAD level to the harmful level. And so if you are putting your patients on niacin for whatever reason, you should check the NAD level because it may be in a harmful range. If niacin increases the NAD to a too high level, you are going to increase the nicotinamide metabolites, 2-PY and 4-PY, which have been shown recently to increase vascular inflammation and cardiovascular risk. So, and also to my knowledge that, yeah, niacin can reduce cholesterol, but it does not really provide cardiovascular protection. Probably because of the increase of NAD and then NAD metabolites and vascular inflammation. That would be my guess.
So to that question, there was another question here. So you can actually OD on NAD. Overdose, it's bad. High doses are bad for you. Is that what you're saying?
Yeah, high doses is bad for you because you are increasing the nicotinamide terminal metabolites. So you do not, based on what we have, you do not want to get NAD levels higher than 100 micromolar based on our test, and you want to get a level between 40 and 100 micromolar, ideally between 50 and 75 micromolar. With niacin, and the levels can go to about 150 micromolar. And also we have some limited data indicating that niacin intake can be associated with increased pace of aging on the epigenetic clock. We don't have a lot of data, but very limited data, but there is a potential. So,
just want to clarify this. So you cannot reach these toxic levels with NR and NMN. It's only through niacin.
You can.
You can also.
You can. So for about 5% of the individuals taking 1,000 milligrams of NMN, and they can go, their NAD can go beyond the 100 micromolar by only about 5%. And with now what's really interesting is people on high doses of niacin, they can have very high levels of NAD, but they don't seem to get the benefit of NAD. They actually they are doing poorly. So my personal opinion is we want to be extremely careful with high doses of niacin because it doesn't seem to provide a lot of health benefits and it has potentially harmful effect. if not monitored carefully. I don't see any reason to take a high dose of niacin.
To that effect, which administration method would you prefer? Oral, IV, intramuscular for NAD?
Well, all right. So, NAD IV does not increase intracellular NAD at all. The NAD you put into through IV is degrading by 50% every 6 hours. So the half-life of NAD is 6 hours. By 24 hours, you got nothing left, almost nothing left in the blood. And so it really does not increase NAD levels in the cells, but extracellular NAD can provide some temporal benefits because they are NAD receptors on neuronal cells and the immune cells. And so the temporal effect of NAD IV come from extracellular NAD, not intracellular NAD. But if you look at the functions of NAD that everyone talks about, it's primarily through intracellular NAD, not extracellular NAD. Even though extracellular NAD is important, I'm not saying it's not important. So you do not for anyone who does NAD IV, my recommendation is you want to also give them NAD precursors, NMNR, after IV, so you can get their intracellular NAD optimized as well. Now, intramuscular or subcutaneous NAD injection actually can increase NAD levels, although very few people can get their NAD optimized because the amount and the frequency that you inject are not sufficient to get NAD levels high enough. And the choice is, you have a very simple and cheap, non-invasive way of oral NAD precursors that work very well versus expensive, invasive NAD injection. And that does not optimize NAD. That's a personal choice. I mean, I think the choice is very, very obvious for me, but I wouldn't tell anyone to what to do. What is unclear to me is whether people can get extra benefit from sub-Q or intramuscular NAD injection that all precursors don't give. I think that's still something that we can potentially study. And my guess is probably not, but you never know, because you are injecting into the muscle and you may get some additional benefits that oral precursors don't. This is a unlikely possibility. That's not really compelled. I'm open to that question.
So basically, PO, oral is kind of your better option.
Oral is the better option. Yeah.
Okay. All right. I think these are questions from your slides about testing panels. They're asking if the difference between just getting a plain CRP versus an HS-CRP would also be indicative of longevity.
Yeah. So CRP is used when in very acute situations because the CRP never goes so high, and you don't need a high sensitivity CRP test, right? So for surgery, if someone's having surgery, you would do a CRP test, not a high sensitivity test. If it's an infection, you probably would order a CRP test. But for chronic conditions, the CRP level is elevating, but not elevating that much. If you order a CRP, you would not be able to detect the difference. So you have to order a high sensitivity CRP. You are measuring the same protein. Is how sensitive is the assay? Can you detect minor changes? And the high sensitivity CRP assay detects minor changes, and the CRP assay detects very high levels of changes. So it depends on the situation.
This one, I think you mentioned during your presentation that you want your hemoglobin A1C in the middle, not too high, not too low.
Not too high, not too low.
All right. Why not low on an A1C? Whenever you go to your doctor, of course, they will always pat your back saying good job on the low hemoglobin A1C.
Yeah,
So why is this detrimental?
you saw the chart. That's the data. So almost every single biomarker, with a few exceptions, the CRP is one exception. If you plot the all-cause mortality on the Y and the levels on the X-axis, you have a U-shaped curve. And somewhere in the middle point is a sweet spot. And if it's too high, you have higher all-cause mortality. And when it's too low, you also have high all-cause mortality. That's almost universally true except inflammation. All right, and maybe closer will be the other one. And these are the only two that I know. You don't want any elevated inflammation. And so why extremely low HbA1c would be bad? That's a very good question. I did not really think about it. I'll have to get back to you.
Sure. So another,
I mean, but the possibility is you have a defect in glycosylation. That's what I can come up now. Because I
right.
was actually talking about this with another doctor today. So we're talking about a very 1-year-old baby girl who has a premature aging, and she actually had extremely low levels of GSP. Now, extremely low levels of GSP is associated with cancer. And now with premature aging. And the only possibility I can really think about is now in cancer patients it's different because many cancer patients are low in albumin. So if your albumin levels are low, your GSP levels can be low. I think that's why we see lower levels of GSP in cancer patients.
Interesting.
But with this premature aging girl, her GSP is low and her A1C is low. I think that's an indication of glycosylation defect or glycation defect. A glycation defect may be harmful as well. I don't know. That's the only thing I can come up with.
Yeah, at least we have theories, scientific theories, right?
Right.
So one of the bigger longevity markers out there is telomere length. You didn't mention that in your presentation. Is that significant?
Yeah, so I did not mention telomere length, for a number of reasons. And the first one is measurement of telomere length has been very difficult, and the technology is improving now. And that's the first reason. The second reason is we do not have an effective way or actionable way of increasing telomere length. And the third reason is telomere length is primarily determined by genetic factors, not by modifiable factors. And so even though having longer telomere length is good for longevity, no doubt about it. But on the other hand, there's very little we can do now to increase telomere length. There is a product. I'm not going to mention the the name of the company, because I actually know the founder, and
Right.
we have some kind of relationship. And that supplement is promoting as a telomere length increasing supplement.
Mhm.
I studied their data. I offered to reanalyze their data, but I have not received the data yet. I have some special ways of looking at the data to. I wanted to see what I can. Well, let me put it this way. I was not impressed by the publication. I wanted to re-examine the data to see whether I can come up with better evidence that the product can increase telomere length in a subset of individuals. And I was trying to find a way to, to dive into the details a little more to see whether I can find any evidence, because I was not impressed by the publication. I, if the product works, we want to know in what subset of the population the product works, right? I'm worried
Right.
about the personalization, precision. If it can help 10% of the population, I'm fine with it. I don't need it to work for everyone. We're never going to find a product that works for, everyone. And if we can solve the problem for 10% of the population with one product, that's great. We'll find another product for the other 10%. And, with a few products, we help more and more people. I have no problem with that approach. But you
Yeah.
have to be able to know who you can help, and at least find a way to tell people you are getting the benefit, but the other person is not getting the benefit. If you get a benefit, you continue. If you don't, you stop. It has to be the decisions have to be made based on data, either before and or after actions. That's what I'm trying to, preach.
Right. And this product is pretty expensive, and I think the heart of the product is astragalus.
Yeah.
So, but anyway, another one would be you mentioned about your clients that are professional athletes. Is NAD use legal in professional sports?
It has to be well, no one said it's not legal, and also I think because NAD is already part of your cellular composition. There's no way they are going to know whether you're taking an NAD product or not, right? Because it's part of your body. It's a naturally occurring substance in your own body, and if they want to outlaw NAD, I don't see how they can implement it.
I
From
think the question was based on WADA policies. So these are the anti-doping societies that checks athletes for doping. I think that's where this question is stemming from.
I well, to my knowledge, they are not testing NAD, and also I'm the first company that can test NAD levels, and I think 95% of the people come to me for NAD testing, and I'm pretty sure they are not testing for NAD.
All right. Okay.
And
And,
a lot of the football players are taking AMN supplements anyways, and
right. So again, check the policies. If the one who asked this question, there is a WADA manual out there that you can look into. I think this comes into a more personal question for you. You mentioned about your daughter,
yeah,
that you actually started her on a longevity plan.
yeah.
So the question was, I think more specifically, how young can you start somebody on NAD? And I
How,
guess your daughter, what longevity plan
so
she's on at
yeah,
that young
so
age?
so uh for individuals younger than 20, I would not recommend the NAD supplementation unless they are tested and are deficient or suboptimal. So, so we supplement our now 8-year-old daughter because she was suboptimal, and our 4-year-old was not suboptimal, so we don't supplement her. Although she fights with her older sister to have a sip from time to time. That's okay. And I think NMN is so safe and is safe for children. I have no problem to give NMN to my 4-year-old, and actually she took some when she was 3-year-old from time to time, and if she is deficient, I wouldn't have any problem to give her NMN. We have some children as young as 2 years old with autism who take the product and get good benefits. And I think before pregnancy, during pregnancy, and after delivery, women should supplement with NAD especially. And I mean, people should supplement all the time, but especially during those time periods. And one thing that OBGYN doctors don't pay attention to is how high the oxidative stress goes up during pregnancy. I believe that's probably related to many of the postpartum issues, and we can deal with that with some simple supplementation, and that it's a much bigger issue that I can take on because people are very careful during pregnancy. I understand it, but these supplements are so safe, and I really think they should become part of the prenatal care. And that's going to take decades for us to make any changes. I feel bad. I feel bad about it because we can help so many people with so safe protocols, but we're not going to. I mean, that's
I think one of the bigger lessons that I got from you is taking NAD can be can be too much. You definitely want to check levels because I have a patient who's taking NAD orally and also an injectable, even doing IVs. And as you mentioned, the metabolites of NAD can be harmful to the cardiovascular system eventually. So I think that's a lesson for me that I hope it gets through our audience also. That's all for me, Dr. Bill.
Okay. Two quick questions. One, what do you consider a low level of hemoglobin A1C?
No levels. Let me bring the slides up. I think it's below 4.2, I believe. Let's get to the.
Because I've seen it, in the labs we have here, it'll just say less than 4.2.
Yeah, is all right. So in the normal population, the risk starts increasing, I would say about 4.7, maybe 5. I mean, I would support 4.7 or somewhere there. For the diabetic is 5, 5.6, maybe 5.2, somewhere in there.
Okay. All right. There's a comment or a question hasn't the FDA banned NMN?
The FDA did not ban NMN, but they sent out a notice to two NMN production companies and telling them that NMN should not be used as a dietary supplement. But the FDA is not enforcing this regulation, and there's also a lawsuit filed by the NPA, Natural Product Association, and we don't know what's going to happen. most of us in the field believe that there's no way the FDA can ban NMN as a dietary supplement because millions of people are using it in the United States and getting great results. Hopefully, IFK, I don't know your politics. I'm not a politician. I'm not in any camp of politics. Hopefully, IFK will reverse the FDA decision. I mean, the FDA has reversed their decision previously, for example, on NAC.
Right.
NAC was in the same situation about 3 years ago, and the FDA sent out a notice, and later on they were forced to issue a non-enforcement notification, if you want. We believe the same thing will happen with
We have the peptides in the same situation too, right?
Peptides are in the same situation, and you know, I hopefully I don't know. I mean, you know, we will have some major changes on the FDA side.
Okay. Somebody asked about dosages on NMN.
Yeah. So you want to start with 1,000 milligrams of NMN, and about 75% of the population will get to optimal NAD levels, and about 25% need more than 1,000 milligrams, and probably 1,500 milligrams daily, and about 5% need less than 1,000 milligrams. So you have to test to dose them out and what's the proper dosage.
Okay. Okay. That's everything here. Just one last question. Going all the way back to the beginning on your simple markers. We used to get fractionated LDHs, LDH 1, 2, 3, 4, 5, and we don't see that anymore. Do you ever use that as a biomarker? Because it's supposed
I do test the LDH in our panel, and because I think it's a good I mean it's a good marker for a number of things, but especially in the biohacker community, I want to make sure that they are not getting damages, and also a lot of people are taking creatine. Now, creatine can increase creatine kinase, CK. Now, when I see a high CK level, I want to know what is due to muscle damage or is just increased muscle mass. So LDH will help me to rule that in or out. And also another related point is if someone is taking creatine, the creatinine level may go up, and many doctors and even nephrologists would get freaked out, and because they see increased creatinine, and they think the kidney function is compromised, which is absolutely not the right interpretation. Because creatine would increase muscle mass, and increase muscle mass will increase creatinine level, and you cannot use creatinine to properly evaluate kidney function anymore. So you want to use the cystatin C, maybe BAN and ACR and other kidney biomarkers in those situations.
What about GFR? Can you use GFR?
You can use the GFR, but very few people measure GFR because it's difficult, and so most people use eGFR or estimated GFR, and most people use creatinine to estimate GFR, and so now we are actually using both creatinine and cystatin C to estimate GFR because of the creatine issue. You don't know how many doctors call me and hey, I got higher creatinine. I mean, I said, did you measure the other biomarkers, the cystatin C and BAN? I said, they said, oh, it's normal. I said, darn, that's what I would expect. creatine is increasing muscle mass. You are going to get more creatinine in some individuals, not everyone, but some.
One last question.
Dr. K, I have a quick question. If you give niacin, pure niacin, does that help with kidney function?
I don't know what the niacin helps kidney function. I don't know the answer.
Okay, because I heard that it's possible people who are having kidney failure, if we give them a pure niacin, the flush one, not the non-flush one,
Yeah,
actually they do much better.
I do not know the answer. Sorry.
Okay.
How long do you supplement before checking NAD levels?
We recommend 3 to 4 weeks after supplementation.
Okay, great. Okay, anybody else have any comments or questions? Well, we can't thank you enough, Dr. Shi. It's been a great night, and I think we all learned a lot. I'm going to shut the